Today we will be doing a hip examination. The main pieces of our hip examination will be posture, functional tests, observation and clearing tests, palpation, range of motion, strength, and then special tests. In this video, we'll focus on general observation and posture examination. Before we proceed to a full in-depth examination, we always assess our patient for any obvious deformity or malalignment. When examining a general posture, we can start either from head to toe or from toe all the way up to the head. We will examine our patient from front or anterior side, posteriorly, and from both sides. I'll start examining from head to toe and anteriorly. I focus on the position of the head and position of the jaw if there is any symmetry or asymmetry of the jaw. Then I proceed to shoulders and I examine the height or any height difference between the shoulders. I assess the muscle bulk and trapezius, deltoid, pectoral muscles. I observe the level of the clavicules on the both sides if there is any height difference, and then I proceed to assess the upper limbs to see how they are rested in the rested position, if there is any difference in the carrying angle, any varus or valgus deformity of the elbows. I assess also the torso, if there is any asymmetry in the torso, what's the quality of the muscle, pectoralis muscle bulk, if there is any difference between the size of the gaps between the torso and each upper limb, which would point to any obvious scoliosis. Coming down from torso, we palpate and assess the position and level of ISEH to see if there is any level difference and height difference. We then proceed to assessing lower limbs. In lower limbs, we assess the muscle bulk on the thighs. Coming down to knees, we palpate and assess the level and the symmetry of the kneecaps or patella. If there is any height difference, if any of them is higher than the other one, or if there is any inward or outward rotation of the kneecap. We then assess the position of the tibia on both sides. Coming to assessing the feet, we assess the position of the feet, if there is any supination or pronation, or flattening or high arch of the foot, and also position of the toes. I can see that John's feet are slightly externally rotated. After I assess my patient from the anterior side, I start assessing my patient from the lateral side. For this assessment, I can use an imaginary plumb line, which is a line straight from the ceiling going through the external auditory meatus, through AC joint, crater trochanter, knee joint, and the medial lateral malleolus. In this position, I can assess if there is any obvious head tilt either forward or backwards, if there is any if the shoulders are rounded to the front, if there is any obvious kyphosis, if there is any obvious lordosis, if there is any obvious pelvic tilt, and also if there is any obvious hyperextension of the knees. Once done that, I can assess my patient from the posterior side. Here again, I'll start with assessing the position of the head, and the anatomical point in this position, or in this side, are the mastoid processes. Again, I palpate them and assess if they're at the same level, at the same height. Again, I'll assess the position and symmetry of the shoulders, muscle bulk. I proceed then to palpate and assess the level of both scapula. If there is any obvious scapular winging, inferior poles of the scapula. Again, what's the symmetry of the torso? Going down to the pelvis, I'll palpate the PSIS and assess the level and the symmetry of the position of the PSIS. Going down, I assess the muscle bulk of the gluteal muscles, gluteal crest. So as I go down, I assess the quality of the muscle bulk of the hamstring. I'll come down to the posterior part of the knee, which is a popliteal joint line. Again, assess the level and symmetry of the popliteal joint line. Moving downwards, I assess the quality of the muscle bulk of the calf muscles and the symmetry and quality of the Achilles tendons. Once completed this is going to be the piece information for my further examination. So in this video, we will clear the joints above and below the hip to make sure that the symptoms of the patient are not coming from the adjacent hips, lumbar spine, sacral, or the knee. We'll start with clearing of the lumbar spine. I'll ask you to bend forward and touch the ground with your fingers. Okay. We can also apply a little bit of overpressure. Okay, now come back to neutral position. Now bend backwards and look up to the sky as far as you can go. Again, stabilize the spine and apply a little bit of overpressure. Okay. The next one is a quadrant test where we ask our patient to put one hand into the pocket of the opposite side and slide down the hand backwards, the back to the thigh. Also stabilize the spine, apply a little bit of overpressure. And the opposite side, it's sort of a rotating and bending movement. Again, stabilize the sacrum and apply a little bit of overpressure. Okay, so when we clear the lumbar spine, we will now continue clearing the sacrum and sacral spine. We'll ask our patient to lie down on the belly in the prone position. The clearing test is a sacral thrust. When we place one hand on the sacrum and we put our other hand on top of our hand and apply first one gentle thrust and then two quick thrusts to see if there is any pain coming from here. If that's cleared, we'll ask our patient to lie on their back in the supine position, and now we can clear the knee. The knee is cleared with the flexion and the extension. We'll ask our patient to flex their knee as far as they can go, and then we can also apply a little bit of overpressure, and then extension, extend as far as you can, and apply overpressure, the extension. If that's no symptoms, we've cleared all the areas that are supposed to go for the hip. Now that we clear the joints up, above and below the hip, we can continue with the hip assessment. We now continue with palpation. Palpation of the hip, we'll start with identifying our anterior superior iliac spine, or ASIS, which is a bony prominence roughly in this area. Once we feel this bony prominence, we'll move to the medial side, roughly 2 centimeters, where we should palpate our psoas tendon. From psoas tendon downwards and medial is our inguinal canal with inguinal ligament, which we can also assess if there is any hernia. We ask our patient to give us a little cough, and we look for any movement or any bulge that would point to a hernia. We then continue further medial, right under the belly button. Once we palpate downwards from the belly button, the moment we hit a bony prominence, that's a pubic symphysis. We can also assess the pubic symphysis by pressing on it as a compression test, which will point us if there is any stress injury of the pubic symphysis. Slightly on the lateral side, from both lateral sides of the pubic symphysis, should be a pubic tubercle. We now go back to our ASIS. Once we are back in our ASIS, laterally, from the lateral side, we can assess or palpate our greater trochanter. Greater trochanter is generally relatively difficult to palpate, so we will ask our patient to do sort of wiggling movement, internal-external rotation, when we feel the moving bony prominence. In between the ASIS and the greater trochanter, there is a tensor fasciae latae muscle, and from that muscle down, we can follow it with the iliotibial band and palpate the iliotibial band. Down to the lateral side of the knee. We can also assess from the anterior side the muscle bulk of the quadriceps and the adductors. We now ask our patient to lie on his belly in the prone position. So once we have our patient in a prone position, we identify the bony prominence from the sides, which is a iliac crest. From iliac crest, we palpate the back to our PSIS, from PSIS down to the sacrum and the coccyx. From the coccyx, we palpate down to the ischias tubercle. In between is a sacrotuberous ligament. From the coccyx to our greater trochanter is a piriformis deep within, covered with the muscle bulk of the gluteal muscle, and then we've got the hamstring muscle bulk. So next set of tests are to test the muscle length in the hips. We've got four tests. The first test is Thomas test to assess the length in the hip flexors. We'll ask our patient to grab their knee and bring it as close to their chest as possible and ask them to relax and lie down on the plinth. And we observe the level of the knee, if the level of the knee is in the same level or the same height as the hip, which would point to, if the knee is higher than the hip, it would point to a hip flexor tightness. Also in the knee, if the knee is more than 90 degree extended, that could also in this test point to a quadriceps tension or tightness. The next test is 90-90, which helps us assess the length or tightness in the hamstring. We've got our patient lying on their back in the supine position, and passively we'll bring up the hip to the 90 degrees and extend the knee as far as possible. with the deviation in the deviation from the knee from the neutral position should be more than 15 degrees. Good. The third test is Obers test to assess the tightness in a tensor fascia latae. We've got our patient on the, lying on the side. We bend the knee to the 90 degrees, stabilize the hip, adduct and extend backwards, and then just let go, relax, and see how low the whole leg sinks. The higher it is, the higher tension in the tensor fascia latae is. And the last test is Elys test to assess the quadriceps. We've got our patient lying on their belly in the prone position. We ask them to bend the knee, and then we passively stabilize the hip and extend the hip as far as it goes without any additional compensatory movement in their hip. Next set of tests help us identify if there is any intra-articular pathology, any problem between femoral head and the labrum. We ask our patient to bring the knee and the hip to a 90-degree flexion. The first test is FABER, flexion, abduction, external rotation. And we look for any reproduction of the symptoms or problems. Again, from the 90 degrees flexion in the knee and the hip, flexion, adduction, and internal rotation. And the third test is Scour test. We'll stabilize the knee, apply axial force from the above the knee, and sort of rotating movements, trying to identify if there is any reproduction of the problems or pain. And the last set of tests are to test the tendinopathy around the muscles that surround the hip. We've got three groups. The first one is abdominal muscles. For abdominal muscles, we do a resisted sit-up. So we ask our patient to bend their knee, and with outstretched hands against the pressure from our hand, we ask them to do a sit-up. And we can also test for the oblique muscles from the side sit-up. And we are looking for any reproduction of the pain, clicking discomfort. We then proceed to test the adductor tendinopathy. For adductor tendinopathy, we've got squeeze test, which we basically place our fist in between their knees in 0, 45, and 90 degrees and ask them to squeeze. So this is in the 0 degrees. We ask them to squeeze their knees, then bend their knees to 45 degrees. Again, place our fist between their knees and ask to squeeze. And in the 90 degrees, hip flexion again and squeeze. And the third is our gluteal tendinopathy. For gluteal tendinopathy, we've got external derotation test. When we bring the hip and the knee to the 90-degree flexion, full external rotation, stabilize the knee. We place our hand at on the outer ankle, and we ask them to bring the ankle to the neutral rotation against the resistance. In these tests, we are looking for any clicking, pain, any discomfort, or any reproduction of the symptoms.